My name is Caroline Schepker. I'm part of Wentworth Health Partners Seacoast Physiatry. I joined the practice in October of 2021. Michelle went through my background, but just as a primer, I did spend about a year and change in New York City during the first wave of the COVID-19 pandemic, at which point I was redeployed to take care of COVID patients in varying capacities, from acute care settings to rehabilitation settings and in the outpatient setting as well. I joined Seacoast Physiatry just a few months ago, and I'm thrilled to be here in the New Hampshire area. I have no financial conflicts of interest to disclose. So the objectives of tonight's lecture. So I'm going to provide a brief overview of COVID-19 and a current snapshot of where we're at in this pandemic. I'm going to talk a little bit about how the virus functions and what we know about the Omicron variant. I'm going to review symptoms and transmission. We'll define and discuss what long COVID is, which is persistent symptoms post-viral infection. I'll do a brief overview of the testing, vaccination, and medical treatment options. We'll discuss evidence-based primary and secondary prevention. And we'll talk a little bit about how to recover at home, including when to seek additional medical attention, as well as multidisciplinary approaches to managing acute or long-term symptoms. And then after that, I'll turn it over to Catherine McDonald, our physical therapist, to talk a little bit more about rehabilitative strategies. I posted this slide here because I think it kind of summarizes where we are in this pandemic fairly well. The purple line here showing the first wave of the pandemic, at which point we were really trying to get our footing and understand what this virus was and take care of acutely ill patients. The second wave, managing more the resources across the country as COVID continued to surge. The third wave, really trying to understand how to manage chronic cases, as well as patients coming to the hospital for non-COVID emergencies and how to fit them into our healthcare systems. But overarching all of this is this red line here, which in some ways is considered a fourth wave, which is ever growing, which is the increasing number of COVID patients who have recovered and convalesced well at home, but have ongoing physical impairments, symptoms, or even social or psychiatric conditions related to their COVID infection or multiple infections. So just a background of COVID, just a reminder of what we're dealing with here. So COVID is an aerosol and droplet-borne viral infection caused by the severe acute respiratory system coronavirus 2, SARS-CoV-2. It is a single-stranded RNA coronavirus. That means that the genetic material that it used, which is shown here in this picture, is what it uses to replicate itself inside a human host. It is all contained within what's called a viral envelope, which has various proteins. You may have heard on the news, people talk about the E protein, the M protein, and the S protein. The spike protein is one we hear the most about, and I'll talk a little bit about that, but that exists on this envelope. And COVID infection, it enters through the nasopharynx most commonly, so the nose and throat. Less commonly, can enter through other mucous membranes, such as the eyes and the mouth. The virus, when it enters the human, usually throat area, it binds to a receptors on cells called the ACE2 receptors, and that little spike protein on the outside allows the virus to attach to human cells, fuse with their membrane, and enter. After it enters, the host cell, the human cell, usually undergoes a series of failed attempts to contain it. The virus will then release its genetic material, its RNA, into the cell, and it will basically hijack that cell to produce and distribute copies of the virus to infect more cells. And I've posted here a really stunning electron micrograph photograph of the virus. This is an actual, real up-close view of what the virus looks like. The virus is yellow, of it exiting a human cell, which is blue and purple on the left and the gray on the right, after it has used that cell to replicate itself. So there are many thousands of variants of COVID-19 or SARS-CoV-2. A variant basically just refers to a strain of the virus that has undergone many different changes or mutations. The World Health Organization has declared 5 variants of concern: the Alpha, which emerged in the UK in September of 2020, the Beta from South Africa in May of 2020, the Gamma variant from Brazil in November of 2020, Delta, which emerged in India in October of 2020, and now what we're dealing with, the Omicron variant, which came from South Africa, specifically the Botswana area, just a couple months ago in November of 2021. A current snapshot of where we're at with COVID. So as of yesterday, January 25th, 2022, there are over 350 million active total confirmed cases worldwide. This is just testing confirmed cases, so it's not capturing the whole view. What do we know about the Omicron variant? So it was first identified late November 24th, 2021. It has an unusually large number of mutations, particularly in that spike protein that allows it to enter the cell, and it multiplies in lung tissue about 70 times faster than the Delta variant. The most common symptoms are cough, fatigue, congestion, runny nose, sore throat, and headache. And its basic reproduction number, which sometimes you may hear on the news people talking about this, it's called the R naught, is 10, which is an exceptionally high number. This is reflective of how many new infections would come from a single infected individual if no preventive measures were taken. So just to put that into context, the Delta variant's R naught was somewhere between 2 and 4. So we are looking on orders of magnitude of anywhere from 5 to 2.5 to 5 times more transmissible. It is probably less virulent, meaning less severe illness. Some studies have suggested that Omicron infections are 91% less fatal than the Delta variant, with 51% less hospitalization. However, I put a little asterisk next to that because this is in the setting of vaccines withstanding. So most likely we are seeing a modification of the severity of illness because that data is collected in areas with high vaccination rates. We know that vaccines provide protection against severe disease and hospitalization, and this effect is increased after a third dose of an mRNA vaccine booster, usually within 90 to 100 days of exposure. So Omicron's extremely high rate of spread, plus its ability to reinfect those previously ill with COVID and those who are double vaccinated, means that the absolute number of patients requiring care both in and out of the hospital is of significant concern because the absolute number is higher than prior variants. So some epidemiologic data from South Africa suggests that patients admitted to the hospital with illness due to Omicron were younger on average. However, the rates of utilization of critical care such as ICU and oxygen therapy were lower than in previous waves. And over 90% of hospitalized inpatients were unvaccinated. Less than 5% had received 2 doses of mRNA vaccines within the previous 8 months. Just an overview of symptoms of COVID-19. So it can have a variable presentation with severity generally inversely proportional to how virulent or transmissible is the variant that we're dealing with. It can infect a wide range of cells and organ systems, most commonly the upper respiratory tract, like the nose, throat, and sinuses, and the lower respiratory tract, such as the bronchi and the lungs. These are the most affected because those ACE2 receptors that the virus used to enter cells are the most abundant in lung tissue. It can also affect the nervous system. We've seen people have loss of smell because of damage to the olfactory neurons, which are the nerves that provide sense of smell. And low levels of the virus have been found in the brain and spinal fluid of patients. It can affect the gastrointestinal tract, as well as the cardiovascular system through viral infiltration into cardiac tissue, because there are those ACE2 receptors in the heart as well. This condition is what is known as myocarditis and can also result in what's called pericarditis. It affects the vascular system in a secondary manner. When people become very acutely ill with COVID, they may develop blood clots secondary to a large systemic inflammatory response, as well as blood vessel injury. And we've seen a lot of reports of kidney damage. The etiology or the cause for this is unclear, but could range from very recoverable mild kidney injury to more permanent sustained kidney damage requiring dialysis. The most common symptoms: fever, cough, headache, fatigue, breathing difficulties, loss of smell and taste, changes in heart rate and or blood pressure. Less common are gastrointestinal distress and neurologic symptoms like numbness, tingling, or weakness. The length of acute illness has a very wide range and can range from 3 to 45 days. And at least 1/3 of those infected with detectable viral loads are asymptomatic. Across the span of this whole pandemic, so since March 2020, roughly 80% of those infected with symptoms will have a mild to moderate course with mild pneumonia at worst and can recover at home. 15% have required some degree of hospitalization due to severe symptoms such as shortness of breath, low oxygen levels, or significant lung tissue damage, and about 5% have critical symptoms, including respiratory failure, shock, or multi-organ failure. The biggest risk factors for severity of infection are increasing age, obesity, smoking, unvaccinated status, and prior medical conditions, particularly diabetes, hypertension, and being immunosuppressed either through a primary immunosuppressed medical condition or being on immunosuppressive medications. So the mechanism of transmission is by and large breathing in air with either aerosolized small particles or droplet large particles components of the virus. The risk is highest when within 6 to 10 feet of a person actively shedding the virus, particularly indoors. This is done with talking, exhaling, coughing, sneezing, or singing. Less common routes of transmission are through the eyes, the nose, the mouth, or surface. So the virus may remain viable on plastic and stainless steel for up to 3 days. It does not seem to survive on cardboard for more than a day or on some metals like copper for more than a few hours. The viral load necessary to become sick this is basically the dose that would cause someone to become sick is anywhere from 200 to 800 virions. That is the measure of unit of viral particles. And symptoms can begin anywhere from 1 day to 2 weeks after exposure. The average incubation period is about 4 to 5 days, and that's the delay to symptom onset. Infected individuals are contagious for up to 20 days, and the pharynx or back of the throat reaches peak viral load about 4 days after infection or within the first week of symptoms. Asymptomatic spread is possible, and again, shedding can occur for about 10 to 20 days. One area of concern is long COVID, which is persistent symptoms after an acute infection with COVID. And so some observational studies have found that some people will continue to experience a wide range of post-viral symptoms for months after recovery from the acute viral illness. They've also seen persistent organ dysfunction or even long-term permanent organ damage. There was one study that was performed in Norway that showed that over 1/2 of a cohort of home-isolated young adults were found to experience a wide range of effects for months after recovery. This was a prospective cohort study. There were 312 patients, 247 of which were home-isolated, 65 of which were hospitalized. Of all of those people, 61% had persistent symptoms at 6 months post-recovery, and 52% of young adults aged 16 to 30 had persistent symptoms. This was independent of the severity of the infection. The number one persistent symptom was loss of taste and smell. Number 2 was fatigue. And then in descending order, shortness of breath, impaired concentration, and memory problems. Various aspects of this long COVID condition are currently areas of active investigation by medical researchers. Just a brief comment on reinfection. So this is an area that is rife with uncertainty, but reinfection with different variants is well documented, and severity may be variable, and any sort of durable immunity after infection is really unknown at this point. Testing, we have several testing methods. There's the PCR, which is a way to detect viral DNA, rapid antigen testing, blood testing for antibodies, and the utility and practical applications of these may be variable because of very limited windows in which some of these tests can capture positive results. Vaccination, vaccines provide acquired immunity. We have 3 vaccines available right now. The Johnson & Johnson vaccine, which is an adenoviral vector vaccine, which uses a more traditional vaccine technology, as well as our 2 mRNA vaccines, the Moderna and Pfizer. Vaccines have substantially decreased the severity of illness and death from COVID, and it is a form of secondary prevention, which I'll go over in a little bit. Vaccinated individuals mitigate individual risk of moderate to severe symptoms and need for hospitalization, but may still carry and spread the virus. So a concept of herd immunity has been a very hot topic over the course of this pandemic. And unfortunately, with rapidly evolving variants and non-durable immunity to different variants and the ability for vaccinated individuals to carry and spread SARS-CoV-2, attempts at herd immunity have been very difficult and likely not feasible at this point. However, vaccination is the number one way to protect oneself from severe illness and hospitalization, likely reduces the risk of long COVID-like symptoms and any organ damage, and mitigates the burden on the healthcare system. In terms of prevention, so in early 2020, some data had suggested that only a small amount of infections are asymptomatic, and asymptomatic individuals may be significantly less likely to transmit the virus. But now we have long-term epidemiologic study from China that has started at the beginning of the outbreak that shows that pre-symptomatic shedding is typical. and that subclinical or very mild infections may have been the source of a majority of infections. So patients seem to shed the most virus anywhere from 2 to 5 days prior to symptom onset. So prevention. So the reason why I want to talk about prevention is because prevention is a key component of recovery, in the sense that the number one way to avoid getting sick from COVID is primary prevention. The number two way to protect oneself is secondary prevention measures, which help kind of fortify the individual and fortify the body against severe illness if a person encounters COVID, which then hastens recovery and will likely make recovery a lot easier process. So secondary prevention basically means if you come into contact with that virus, how can you mitigate your chances of having a severe reaction to it? And so vaccination is probably the number one form of secondary prevention. We know that double vaccination with an mRNA vaccine offers at least 30 to 40% protection against infection from Omicron and 70% protection against hospitalization. A third recent booster dose increases these values to 75 and 88% respectively. Forms of primary prevention, meaning ways to prevent even getting the virus at all, we still are talking about things like physical distancing. And I use that term because it's not social distancing. You can still be social and have an active social life and connect with loved ones, but physical distancing really means keeping an actual physical distance from people, especially people you don't share a home with regularly. Limiting indoor gatherings and avoiding crowds, adequate ventilation, hand washing and personal hygiene, so soaps and detergents inactivate the virus by disrupting its lipid capsule. Using soap and water, a minimum of 20 seconds with hand washing. The alcohol-based hand sanitizer is also effective. It needs to have a minimum of 60% alcohol, and avoidance of touching eyes, nose, and mouth. Surface disinfection with thorough cleaning, and face masks. We have some data now that really gives us a good sense of which masks are effective. So respirators and N95s are the most effective, which are more effective than KN95s, which are more effective than multi-ply, well-fitted surgical masks, all of which are far superior to a simple cloth mask. And none of these should have any vents or valves. It's just a pretty straightforward study from the University of Colorado at Boulder, which shows risk of contracting a virus in different settings, and not basically if you're in a ventilated area versus poorly ventilated area, outdoors versus indoors, and what activity you're doing. And not surprisingly, the green, the lowest risk of contracting virus is outdoors when silent, and the highest risk is when you're in a poorly ventilated area performing heavy exercise. And this is because, again, you're in an environment where exhaled respiratory particles can build up indoors. So talk a little bit about current treatments. So there are no specific treatments at this time. For the majority of people who catch COVID and have a mild to moderate illness and are able to recover and convalesce at home, the standard of care for outpatient treatment is supportive. And supportive means basically supporting the body to heal, give its best shot at healing, give the immune system its best shot at fighting off the virus and recovering well. So there are various ways that we do this. Number one, over-the-counter anti-fever and analgesics such as Tylenol and NSAIDs can be used for fever, headache, body aches. Sufficient fluids with electrolytes to make sure blood volume is being maintained to optimally perfuse and bring blood flow to organs and remove waste products. Adequate nutrition and adequate rest to really allow the immune system to do its job, with a graded return to physical activity and productivity as tolerated. On the inpatient side, the current standard of care for patients who are hospitalized can be variable, but it's also largely supportive care to relieve symptoms. At that higher level, patients in the hospital may need some fluids, some oxygen therapy. They may receive steroids or immunotherapy. They may get pain medications, different positioning to improve lung aeration, medications to treat concurrent infections, blood clots, or other secondary conditions. These patients, if they're in bed for a while, may require some degree of inpatient rehabilitation and a transition to outpatient rehabilitation and ongoing medical management if needed. In terms of current treatments from a medication standpoint, so in the inpatient side, corticosteroids such as dexamethasone and certain immunotherapies such as monoclonal antibodies, one known as tocilizumab, have been used for severe illness and do seem to help hasten recovery in certain subsets of severely ill patients. Monoclonal antibodies is an area where testing and research is still ongoing. Some preclinical data suggest that some of these therapies have been able to neutralize Omicron, but the vast majority so far have been ineffective. There are several experimental theoretical therapies in the pipeline, but have not yet been used for human use. I've listed a couple of them here. And then actual drugs in the pipeline that many of you may have heard about on the news. So Merck and Pfizer have both developed antiviral drugs. Lagevrio is the brand name for the Merck drug. Paxlovid is the Pfizer one. Both were approved in the UK in November and received emergency use authorization by the FDA in December of 21 here in the US, but they are really highly restricted medications right now that are mostly undergoing study in study populations of highly vulnerable people who have contracted COVID in the community and have a high risk of progressing to severe illness. So people with multiple comorbidities that could put them at risk for getting hospitalized. In order to mitigate severity of illness, there are several things that we can all do. Number one is vaccination. There are a couple of other areas that have been studied with regards to trying to improve the body's immune response. And there is some preliminary data that suggests that vitamin D status and possibly supplementation can be helpful. So vitamin D is actually not a vitamin, it's an immune modulating hormone. And an October 2021 meta-analysis showed that some vitamin D supplementation in COVID positive patients may mitigate symptoms ranging from mild to severe. A study published in the Journal of the American Medical Association from the University of Chicago last year showed that having vitamin D blood levels slightly above those traditionally considered sufficient may lower the risk of symptomatic infection. So currently what's considered sufficient is anything over 30 nanograms per milliliter. This study found that anything at 40 or higher seemed to have a significant effect on having a symptomatic infection. There are also studies looking at critically ill patients that suggested that high dose vitamin D given to those severely ill hospitalized patients in what's called a pulse dose decreased those patients' length of stay and markers of inflammation. A couple of other studies have suggested that zinc supplementation may also reduce incidence of symptomatic COVID infection in anywhere from a 10 to 50 milligram dose. However, this is not something to be used long-term for long periods of time, as zinc can interfere with absorption and action of other minerals in the body. Some other ways to mitigate severity of illness. So maintaining a healthy weight, a BMI of less than 25 is significantly associated with decreased risk of hospitalization. And in those hospitalized, a BMI within a healthy range of 18 to 25 is associated with a decreased length of stay and increased survival. Physical activity, so 150 or more minutes per week of exercise is associated with a decreased risk of hospitalization and death, even independent of BMI. And adequate sleep and healthy diet, both of which can help modulate immune function in a favorable manner. So recovering from mild COVID at home, make sure you have adequate rest and high quality sleep, and gradually returning to physically and mentally demanding activities using, I would say, what's called an RPE, or rating of perceived exertion. And Catherine will go into this a little bit as well, but going through a perceived exertion scale can sometimes be a little bit more effective than looking at things like heart rate. Taking breaks from technology, making sure you have adequate hydration and nutrition. All of these things taken together support the immune system and organ systems through optimization of lifestyle. When to seek medical attention. So there are some symptoms that would definitely necessitate reaching out to your primary doctor or even going to the emergency room. And those would be, after COVID infection, having shortness of breath at rest, shortness of breath with even minor exertion that persists past 4 weeks, any neurologic symptoms like new sudden numbness, tingling, or especially weakness, new leg swelling, which could signify that there may be a blood clot, or chest pain. Regarding long COVID, so the World Health Organization definition is a condition which occurs in individuals with a history of probable or confirmed COVID-19 infection that have symptoms that persist for 2 months following recovery from acute infection and cannot be explained by an alternative diagnosis. So the most common symptoms are headache in 44%, fatigue in 24%, shortness of breath in 24%, musculoskeletal symptoms such as joint pain in 19%, chest pain, physical limitations, depression, palpitations, and insomnia. These symptoms may fluctuate or go away over time. And the main risk factors for long COVID symptoms are pre-existing health conditions, psychiatric disorders, high blood pressure, immunosuppression, and obesity. Several studies have shown an association between vaccination and decreased self-reporting of long COVID type symptoms. There was a study recently published coming out of Israel, which looked at 951 people previously infected with COVID, aged 18 plus from March 2020 to November 2021. 35% reported not fully recovering at a 2-month follow-up with reports of fatigue, muscle pain, and headache. However, vaccinated people who in Israel had received the Pfizer vaccine for at least 2 doses had anywhere from a 54 to 82% reduction in reporting of long COVID symptoms, depending on the symptom in question. Interestingly, vaccinated individuals were no more likely to report long haul symptoms than control subjects who had never even been infected. So managing post-viral symptoms. So there are various ways to manage symptoms, ranging from pharmacotherapy, so medications to help alleviate symptoms, which can be used on a short-term or temporary basis, different lifestyle approaches, exercise, rehabilitation, optimization of nutrition, and mind-body therapies. For patients who have persistent symptoms, it may require a multidisciplinary approach to recovery. So most symptoms will resolve themselves in time with adequate rest, taking care of your body. Persistent symptoms that are mild can most likely be addressed with a primary care doctor. However, persistent symptoms that are more concerning and involve specific organ systems may require some input from pulmonology, cardiology, ears, nose, and throat specialists, physiatrists like myself, or neurologists. And then lastly, other services that are available in the community that can help patients recover who are having persistent symptoms include psychiatry, behavioral and mental health, and physical, occupational, and speech therapy, as well as vocational rehab for those who are finding it difficult to return to work because of persistent symptoms. So this concludes my portion of this talk. My takeaways for you, I would say the main ways to ensure a relatively pain-free recovery from COVID should one become infected are to get healthy and stay healthy. Primary prevention through avoidance of sick people, physical distancing, masking, and so on. Secondary prevention through vaccination, possibly talking to your primary doctor about maybe having your vitamin D levels checked and considering a supplement if low. All of these work together to decrease the risk of severe illness, which will improve the chance at easier recovery and decrease chance of long haul or long COVID type symptoms. Just know that resources are available within the community and our hospital system or your local hospital system if needed, and know when to reach out for help, either due to persistent symptoms or some of those more severe symptoms, as I mentioned earlier, that may require more prompt medical attention. So I just want to thank you very much for your time and attention. We'll open up for questions towards the end, but right now I'm going to turn it over to our moderators and to Catherine McDonald, our physical therapist, to continue talking about the rehabilitative approach. And these are just a couple of slides with my references.
Thank you, Dr. Schepker. Just give me one moment and I will share my screen. All right, so I'm now going to continue discussing more of the rehabilitation side of things. So to begin with, I do not have any financial conflicts of interest to disclose. And what I'm hoping to accomplish is that individuals understand how therapy can assist in post-viral symptoms, and I will be including PT, OT, and speech therapies, how to begin an exercise program, and also identify some resources for those of you in the community. So one of the things I wanted to begin with is just my knowledge and passion regarding COVID. And when in April of 2020, when it first came to Boston, I was redeployed to the Boston Hope Medical Center, which was the field hospital set up in Boston. And I was there for the 2 months that it was open. And so, although I was working full-time at Spalding Rehab in Boston at the time, I gained extensive experience working with individuals who had suffered from COVID, and also gained a lot of knowledge at the same time. And I was fortunate to work with a number of PTs, OTs, and speech within the MGB network, including MGH, Brigham and Women's, and Spalding. And then we also had the Army Reserves helping us as well. And then upon return to my full-time position at Spalding, there was very limited research at the time regarding rehabilitation in the outpatient setting. And so a colleague and I started delving into the literature to figure out how we could best treat these individuals in the outpatient setting. But however, there continues to be a lot more to learn as research continues. So as was already discussed, there are a number of post-viral symptoms, and they can be diverse and affect many or multiple organ systems. So the symptoms highlighted in red are some of the topmost symptoms that are reported post an infection. So symptoms that we can treat with therapy can be some endurance, balance, any neurological deficits, pelvic floor dysfunction, pain, fine motor skills, brain fog, weakness, and any cognitive discussion. This may not be a completely inclusive list. So if you are having other symptoms, it does not hurt to speak to your physician to determine if a referral to therapy may be indicated to assist with recovery. So with occupational therapy, occupational therapists can address functional activities such as bathing, dressing, eating, opening containers, pouring a glass of water, reaching for items in a cabinet, any sensation changes, and weakness or pain in the arms. So if you are referred to occupational therapy, they'll probably take a look at some more fine motor tasks, take a look at strength in the hands with any pinch or grip. They're going to work with you on activity tolerance and energy conservation. If you have unfortunately been hospitalized, and especially if you, proning was something that you were treated with, there may be a brachial plexus injury, which occupational therapists can assist with that recovery. There are some reports of vision impairments, and then occupational therapy can also assist with return to employment and return to driving. So their treatment is going to focus on that activity tolerance, that energy conservation, that fine motor strength and coordination. And they can also assist with any weighted utensils or grooming tools that may be needed to assist with tremors. As far as physical therapy, areas that can be addressed are strength, endurance, balance, posture, respiration, postural orthostatic tachycardic syndrome, or POTS, dizziness, and any pelvic floor dysfunction. So for those who are not familiar with POTS, there are multiple triggers of POTS, and it's used generally, this is an increased heart rate of greater than 30 beats per minute within a 5 to 10 minute period of standing, with no significant changes or minor change in blood pressure. And so there are many triggers for POTS, and they include surgery, pregnancy, psychological stressors, concussions, infections of the gastrointestinal and respiratory tracts. And therefore, because COVID is a respiratory viral illness, it may trigger POTS. And there have been more cases of POTS documented in females, though there is no correlation with the severity of COVID. So when we think about general guidelines to exercise, when we think about aerobic conditioning, we do think about where your heart rate should be. And so we calculate that age predicted maximum heart rate, which would be 220 minus your age. And we want to begin exercise within 50 to 70% of that maximum age predicted heart rate. And the goal for aerobic conditioning is 3 to 5 times a week for 20 to 30 minutes. And I will go into further detail of how to actually achieve that, as it doesn't have to be achieved all at one time. We want to think about more interval training. So starting with a short duration, low intensity. That's something that we think about for 6 to 8 weeks. And we also think about strength training and progressive strengthening, resistance training, and increasing the repetitions before the weight. The key thing is to remember to obtain clearance from your physician prior to the return of exercise to make sure you are deemed safe to return to exercise. So when we think about how we monitor symptoms, Dr. Schepker did discuss about the Borg scale, which looks at activity level. And we also have the modified Borg, which is the dyspnea scale, working on shortness of breath. And so these are two scales that can be very important to figure out how much activity is beneficial for you. So if you notice a rapid rise in your heart rate with exercise, this is likely related to deconditioning, though you want to therefore adjust your exercise program accordingly. And you may find just a really rapid rise in heart rate just getting out of bed and walking to the kitchen in the morning, and that will begin to give you that guideline of exercise. So when we think about the Borg scale, we want to focus more in this green area, which is maybe a somewhat hard activity. And when we think about the dyspnea scale, we want to think about more moderate to somewhat severe shortness of breath, but not going to that severe point. And if you do have either a smartwatch or a pulse oximeter at home, they can obviously measure your heart rate and oxygen. Some smartwatches can measure your oxygen saturation. And so you want to think about keeping your oxygen saturation or not have it drop lower than 88% and to stop exercising if that oxygen saturation drops below that 88%. Keep in mind that if you are taking a beta blocker, this will blunt your heart rate with activity, and therefore you only want to be measuring your activity through the exertion and the shortness of breath scales, and not even considering what your heart rate is. So when we think about aerobic conditioning, just a basic walking program is a very easy place to start. And you can even start with just walking within your home if walking outdoors is not feasible. So as I previously mentioned, focusing on achieving 20 to 30 minutes a day of activity is beneficial. But an easy example of how to think about beginning your walking program is just thinking about 5 minutes, 5 times a day for week 1, and then increasing to 10 minutes, 3 times a day for week 2, and then increasing to 15 minutes 2 times a week or 2 times a day for week 3. So each of those times gets you between 25 and 30 minutes of walking per day, but you don't feel like you just have to go out and walk for that considerable amount of time. There may be times you do need to actually come into physical therapy as well for treatment. So if there's any pelvic floor dysfunction coming on, your physician will need to refer you to a pelvic health specialist. If there are any reports of dizziness or imbalance, a referral to a vestibular therapist would be beneficial. If you are suffering from POTS, a referral to PT is beneficial. And we do have a individualized, or we'll start you on an individualized exercise program. And then if you're unsure of how to safely begin exercise, always speak to your physician, and that referral to therapy is always warranted. Depending on the severity, excuse me, of COVID, and if you have shortness of breath, pulmonary rehabilitation may be beneficial. And pulmonary rehabilitation is a guided exercise program that entails individualized aerobic exercise, airway clearance techniques, oxygen, and nutritional support. And it does improve the quality of life, and it is offered within the MGB network at many of our locations. And so with pulmonary rehab, they'll be including breathing exercises to strengthen the muscles of your chest, and then muscle strengthening to address any weakness of the lower extremities or the arms that may have been lost during a hospitalization. And there are studies that support the efficacy of pulmonary rehabilitation in improving exercise and lung function capacities, in addition to symptoms of fatigue, dyspnea, and mental health for those who have suffered from COVID. So for speech therapy, a lot of this research is coming out of those with respiratory illnesses who have previously been in the ICU. So there may be swallowing issues if there was a prolonged intubation. And then also, if you have shortness of breath, there can be an abnormal breath and swallow coordination, which can be associated or then cause aspiration. There may be some voice and respiration challenges. So if there was difficulty from weaning from mechanical ventilation, or if there's some weakness, including that diaphragmatic weakness, that is something as part of speech therapy or treatment for speech therapy. And then the cognition, they're the cognitive part. And so there are many components of cognition that can be affected. And what we do know from those who have had a respiratory illness and have been in the ICU, that the cognitive impairment can affect 70 to 100% of patients at discharge. And those symptoms can then linger a year and even 5 years later. And when we think about the cognitive aspect, we're thinking about attention, visual spatial abilities, memory, executive function, and working memory. So for treatment, if there are any swallowing difficulties, it will be a patient-centered swallowing treatment. There are more bedside evaluations that can be completed, but there may be an instrumental assessment that may be indicated depending on the severity of the swallowing challenges. As far as the voice and the respiration, speech therapists can work on breathing exercises and working on the inspiratory muscle training, the deep, slow breathing, diaphragmatic breathing. It will be patient-centered vocal phonation exercises, and there may also require follow-up with an ENT if indicated. And for the cognitive part, assessments will be completed, and therefore treatment will be centered around those impairments, while also considering that energy conservation, because surprisingly, there is a lot of cognitive and memory effort that can greatly fatigue individuals, and that's where energy conservation is also very important. And then there will also be indications for just the functional outcomes, which may include that return to employment or that return to school. So some general guidelines to think about from the rehabilitation aspect is communication and socialization is very important. However, in light of the pandemic, we may need to consider telephone and video calls when face-to-face interaction is not feasible due to the health and safety of all individuals. Nutrition and eating a healthy diet is really important. Remember that exercise and movement is important. So even when you are so fatigued, getting up and developing a structured routine is actually one of the best outcomes that you can to have to manage the fatigue, and getting a good night of sleep. So aim for approximately 7 hours, and improving your sleep hygiene by going to bed at the same time and waking up at the same time each morning, and trying not to nap during the day if possible will also help with getting you on that structured routine and help with some of the symptoms as well. So there are some resources in our community. And so Spalding actually does have a virtual support group once a month on the third Thursday of every month from 3 to 4:30 p.m. You do need to register ahead of time. The January discussion was about GI issues, diet and nutrition, which unfortunately just occurred last week, but upcoming in the next 2 months for February is managing relationships when chronically ill. And March is treatment options for and the latest research for long COVID. As part of the Spalding Adaptive Sports Program, they do actually also have a yoga program, which focuses more on breath and energy. And this is virtual again, so this is via Zoom. And again, you do need to register ahead of time. And then further afield outside of our network, Johns Hopkins and New York Presbyterian have both developed great handouts that are accessible to everyone in the community regarding recovery and movement, and go through some exercises as well. However, if you don't feel comfortable doing exercise on your own, that is when you should definitely seek that referral to therapy. So in conclusion, I just want to say that prevention of COVID is invaluable. So wearing a mask, vaccination are key. Understanding of the virus is evolving each day, and therefore what we are presenting today may not be the exact information that may hold true tomorrow or even a month or 2 months from now. We are continuing to learn about how and why the virus affects individuals in a variety of ways. Some individuals have no symptoms and others have life-threatening symptoms. As new insights evolve, this will provide guidance for those who are living with long-term COVID-19 effects. As Dr. Schepker also discussed, a multidisciplinary team of providers is important. So this may include any of the rehab services of PT, OT, and speech, physiatry, psychology, neurology, cardiology, pulmonology, social work, nutrition, and the list could go on. If you do come to therapy, understand that rehabilitation is personalized. So it's not just a general bowl that we put you in and do the same thing with everyone. We are focused on your exact impairments. But the key is start moving. Movement heals the body in ways that restore the mind and also soothe the emotion. So this is definitely a key part, even when you don't feel great.